Welcome to the second of our 9-part series on emergency planning. The session today will focus on what's new with emergency preparedness ruling Appendix Z. My name is Christy Fable, and I am a quality improvement advisor with Superior Health, and I will be facilitating today's call along with my Superior Health colleagues, Allie Albers and Mike Bitten. Before I introduce our speakers for today's call, I want to take this time to review just a few housekeeping items. We will be posting the slide deck several times into the chat for your convenience. Please feel free to add questions and comments into the chat box as you think of them, and we will answer questions at the end of the call. There will also be an opportunity to ask a live question at the end of the call, and we will review that process just a bit later. The series is being recorded and will be available on our YouTube channel in about 2 weeks, which will allow you and your team access to the recordings on demand when it is convenient for you. We will also post an evaluation link at the end of today's call, and we would appreciate it if you would take a few minutes to complete it for us as we use the evaluations to improve calls and to determine if there are other topics you may find information about how. So at this time, I would like to welcome our speakers, Brian Kaczmarski and Amy Woolman-Neseth, who will be introducing themselves. Welcome, Amy and Brian.
Thank you very much. These are the two objectives today that we will be looking at, primarily describing the key components of Appendix Z, and we'll talk about the history of that in just a minute, and then also examining opportunities to include these requirements into your emergency preparedness planning. So my name is Amy. For those of you who weren't on the call last time, I'm the co-owner of Optima EP Consultants, Emergency Preparedness Consultants. I'm also currently the Northwest Wisconsin Healthcare Emergency Readiness Coalition Coordinator, which in Wisconsin, the mail truck comes at the same time every Thursday. In Wisconsin is the Healthcare Coalition. So depending on what state you're in, sometimes the name of that coalition is a little bit different, but we are Healthcare Emergency Readiness Coalitions in the state of Wisconsin. I'm also a former board certified chaplain, and I'm an approved instructor for the International Critical Incident Stress Foundation. Brian?
Thank you, Amy, and hello, everyone. My name is Brian Kaczmarski. Like Amy, I am a HERC coordinator for the state of Wisconsin. I happen to have the title of statewide HERC program coordinator. Simply means I support the 7 HERC structures within Wisconsin. My background is in public health. I was a former local public health officer, and really with an emphasis on emergency preparedness.
So I want to start today with a disclaimer, which is saying that what we're going to be presenting today is an overview of Appendix Z. But when your surveyors come to your facility, if you say, well, Amy and Brian said, this is the way we're supposed to do it, or this is what we need to have in our plans, that probably won't fly. So it remains your organization's responsibility to make sure that you are meeting the expectations of the emergency preparedness ruling. Brian, I'm still getting a little echo, and I think it may be because you're unmuted. There we go. So I did put in the links here for both Michigan or Minnesota and Wisconsin for the state regulating agencies and their information about emergency preparedness. So if you have any doubts or questions about the regulations, those really are the places that you need to go to, because that's where the surveyors are coming out of. So a little history lesson. In September of 2016, the Centers for Medicare and Medicaid Services published a new federal ruling that talked about emergency preparedness for agencies that are surveyed and regulated by the CMS. Those were 17 different provider types. So that ruling didn't go into effect until 2017 in terms of that's the date at which point you could be cited for not having the emergency preparedness rules and regulations integrated into your organization. In February of 2019, there was an updated document that came out regarding interpretive guidance. And then in September of 2019, there was further additional guidance because of the some of the feedback I think that the federal government was receiving. And they called that the burden reduction rule. Then, of course, we all know what happened in 2020. And so in March of 21, they released yet another update to the emergency preparedness ruling that is now lovingly referred to as Appendix Z. This is a very important document that you need to know and know well, because it talks specifically about what the requirements are for this emergency preparedness ruling. And Appendix Z specifically has some additions that are key that we're going to talk about today. And these are additions that were born out of the lessons learned from COVID. So when you go to Appendix Z, again, I think it's important to think about this document not as a intended as a punitive document. Yes, it's a regulation. Yes, it's something that you must do, but it really is a demonstration, in my opinion, of the commitment to quality improvement, which is something that we talked about in our presentation 2 weeks ago. That developing that culture of emergency preparedness is really about having a commitment to a culture of quality improvement. So the reason we keep getting different variations of this document is because we continue to learn with each and every disaster or public health emergency that we live through. And so Appendix Z really is a reflection of some of the lessons that we've learned from COVID. And there have been additions to the regulation, but it's all based on how do we become better in meeting the needs of our clients, our residents, our patients, and our staff. So Appendix Z, it's important to remember that there are 17 different provider types that are covered under this ruling. It's not just long-term care facilities and not just hospitals. When you go to Appendix Z, you will see that there's a list of all of the different types. This is just a snippet of that, but it's really important that you're looking, of course, at your own regulations for your type of facility. The other thing that's very useful in Appendix Z is with the most recent changes are highlighted in red. And so you are able to scan through the document and see what has been added or what has been changed from a previous version. If you are new to emergency preparedness, you need to read the whole document and not just the red. Today, Brian and I are going to be talking about the changes, so the additions that are in red, but this is a fundamental document that you need to have a pretty good grasp of from a foundation level as well. One of the really great things about this document is you can search for survey procedures, and it will direct you to each section where there are questions that are asked that are similar to the questions that your surveyors may be asking you. And you'll see some of those in our presentation today. I lifted a few of those just to give you an idea of what those look for. But that's a great way to kind of do a checklist to see, have we met everything that we need to meet? And then every reference that we make to a page number today comes directly from Appendix Z.
So, as Amy mentioned, at the beginning of all things emergency preparedness, you or your agency or your organization developed a plan. This is referred to as your emergency preparedness plan, or sometimes an EOP, emergency operations plan. Essentially, Amy and I will use those two terms interchangeably, EOP, ERP. To start out with, here are the big four chunks of what makes up an emergency operations plan. You need to have some type of a risk assessment that helps you to identify what your most likely threats are to your facility. You need to have a communications plan. And I like to tell people to think about your communications plan as who do we tell on the inside and who do we tell on the outside? So who are we going to and how are we going to communicate to our clients, their families, our staff that are not on site at the moment of the big bad thing? And then how are we going to let our outside partners know what's going on as well? And we'll get into comms plans a little bit more. All of your policies and procedures, we try to prevent and mitigate. That always happens first in the preparedness cycle. But for the things that we can't prevent or mitigate completely, we have to have policies and procedures in place with the likelihood and understanding that those things could happen. And then finally, we need to have a training and testing program that is a reflection of our risk assessment. So that training and testing piece shouldn't just be generic carte blanche training around preparedness. It should point to the top things that are identified within your risk assessment. And you can teach off of the policies and procedures that you have, but you can see how that cycle works. Risk assessment, training and testing, update policies and procedures, rinse and repeat. Okay. As the next slide shows, again, what is an EOP? It's your strategy for responding to and recovering. Okay. And I want to really emphasize that word recovering. I think for the most part, we are getting better, not only in the upper Midwest, but around the country. We're getting better at responding. We don't do so well at recovering. And that is a tangible component of emergency preparedness and response. And we'll get into a couple of reasons why that happens. One of the key areas that I want to emphasize is on the second bullet point, C, quick response, abbreviated guidance, quick reference material. When I started out in the world of preparedness, we wrote very robust, comprehensive plans that were heavy in narrative. And that's because at the time, our federal funders said we had to have that type of narrative and background into our plans. We don't see that very much anymore in emergency response plans. What we see in emergency response plans now are checklists, process flow maps, very simple visuals and one-pagers that can quickly get a function and a response stood up so that you can get caught up to that incident and hopefully get ahead of it so that you can start to mitigate the damage of whatever that incident is. And then finally, the incident command system. I know this is the part where everybody gets to the edge of their seat because it's riveting. That really does need to serve as the foundation of all things within your emergency operations plan. Number one, because it's a requirement. Number two, because it's standardized. And number three, when you have outside partners that are going to come in and help you with a response, these are people that you're not used to working with on a day-to-day basis. It's important to have that standard terminology and that standard structure in place so that you can seamlessly integrate all of those key players into your response, and not everybody's not looking at each other going, well, what's your job? What's your job? And I thought you were doing that, or I thought he was doing that. So that's the importance of the incident command system. The incident command system, there are variations of the incident command system. There's the federal incident command system. There's something called HICS, the hospital incident command system. And there's even a nursing home incident command system. For the most part, they're relatively the same. There are a few nuances between them that simply provide more detail and specifics to that particular provider type. We have a future training specific to this in our 9-part series where we will go more in depth. The one thing that I would like to draw your attention to, regardless of the type of the incident command system that you use, I want you to think about, everybody thinks that the incident commander is the most important role in emergency response, and it is a critical role. It's a necessary role. I would challenge you that a scribe is the most important role in the incident command system. And think of a scribe as nothing more than a note taker, somebody that is archiving the events that are going on, and they should be tied to the hip of whoever that incident commander is. It's going to save you countless hours of tracking things down after the response and making sure that everything is documented properly. So some new guidance, again, specific to Appendix Z for your particular emergency operations plan. Now, again, Amy and I are at a 50,000 view. Always remember provider type, the state agency that is providing oversight to you. They may have slightly different interpretations for that. So there is no prescribed format. There is no prescribed structure for your emergency operations plan. It doesn't mean that this section needs to go first and then this section needs to go second. But I do think there are some best practices out there. Some of the newer things that are required is under what circumstances would you activate those emergency procedures? In our world, we call that triggers. What are the triggers that would cause us to go from blue skies operations into some type of emergency response mode? If you go to the letter of the definition of the National Incident Management System in ICS, the definition is anything that causes you to have to operate at above what would be considered daily operations, normal daily operations. That could be a trigger point for you to go into some type of emergency response. And that's going to vary for every agency because you all have different resources, you all have different amount of staff, you all have different client bases, and to be honest with you, you're all going to have different risks. So that's a very variable trigger point. Your plan must also indicate who is authorized to pull the trigger on activating that preparedness response. Is it your chief administrator? Is it your preparedness planner? The key on that is whomever it is, it has to be documented in your plan. So who is authorized to trigger that plan needs to be documented in the plan. And then the last piece, again, providing CMS when they come on site, first off, hand them the flowers and a box of chocolates, and then provide written evidence of your emergency preparedness program. General guidelines is this plan must be updated and reviewed every 2 years, except for the caveat for long-term care facilities, which is an annual requirement. And I would even drill down a little bit further that if you happen to have an incident within that annual cycle, I believe that incident would be cause for an update of that plan. And that's that corrective action piece. And then in terms of retention, documentation, as you can see on the last bullet point, we generally recommend 4 years. Track back 4 years of emergency training documentation, archive that, and then as time goes on, you can cycle that out. But always have 4 years worth of evidence of your documentation and training. Continuity of operations or COOP planning. I'm going to give you the old definition of COOP planning. When we used to think of COOP planning, it really only referred to that middle box, that clinical care. That's what we really used to focus on. If you had to go into contingency or crisis operations because of some type of event, the focus was really on still providing clinical care, that being safety and quality. During an event, you have to show that the level of care that you're providing to your patients is the same as it was prior to the incident. It needs to stay static throughout the course of that incident. However, COOP more recently has broadened its scope, and now you can see that not only do you need to maintain that clinical care, but that business continuity and those essential services pieces need to be integrated into your continuity of operations plan. And we've seen that as a result of best practices from where those two particular areas weren't focused on during a response, and it really caused that incident to drag on for a longer period of time. So through best practices and corrective actions, COOP really is these 3 key bullet points right now. All hazards planning is exactly what it says. We want you to be able to, we cannot predict everything that could happen to our facility. We cannot predict everything that could happen to us. We have no idea if a balloon is going to fly over the top of us, current events and things like that. But the approach calls for an all hazards approach. So the example that we like to use is, don't necessarily plan for a tornado, plan for what you would have to do as a result of that tornado. So we either going to need to evacuate or we're going to have to shelter in place. So think more broadly in terms of just these are the risks, but what would be the functions that we need to implement in order to get through whatever that challenge is. So that last bullet point challenges you to say, well, typically in blue skies events, what are our essential functions within our facility and based on our provider types? You still need to provide those essential functions during the big bad thing. You just have to do it with one hand tied behind your back because you're dealing with those things as well as whatever the big bad thing is causing your facility to have to do as well. So we want you to be able to think about developing your EOP based on that risk assessment. So think top 5 threats using an all hazards and community-based approach. And what we mean by that is we all know events start local and they end local, but somewhere in between that response, that bell-shaped curve of the response, there's a very good likelihood that you're going to need to call in support, or you may be called in to provide support to a local partner as well. That community-based approach is really, it's not so much getting the entire community involved. It's more of understanding what your community's response plans and protocols are as well. Because you don't want to have the same evacuation plan as the 2 other nursing homes within the jurisdiction. Because if you're all going to end up evacuating to the hospital is number 1, not going to be able to take all of you. And number 2, they're going to have an issue with being written in to your emergency response plans and not necessarily knowing that that was their function. So looking at it from an inclusive standpoint, how can we help our partners within the community and vice versa? How can they help us? So being involved in local emergency preparedness committees, sometimes they're called LEPCs, local emergency preparedness committees. Getting together with your community partners on a regular basis is critical, if for nothing else, information sharing and an understanding. Doesn't need to be a detailed understanding, but a general understanding of what everybody else is going to be doing so that we can all utilize the collective resources that we have and we're not being redundant with each other. Amy, you're on mute.
Sorry. So the next section is talking about risk and vulnerability assessments. And again, I want to be clear that we are going to dedicate an entire session to this topic. I believe it may be the next one in March, but we definitely will be spending more time talking about this. There are many, many different types of risk assessments that you can do. A very common one is the Kaiser Permanente version, which is available for free on the web. But there are many other types that you can download, or you can create your own, or borrow and steal from other people. There are many different forms, but common to all of them are the types of emergencies. So even though we talk about planning by function, in the HVAs, the hazard vulnerability analysis, we still do talk about specific threats. And you are supposed to look at the probability of a threat happening, what kind of impact it would have on the human impact or your business or your facility, your infrastructure, as well as what types of efforts or mitigation efforts have you had to try to lessen the impact of that type of event. And then eventually you end up with a score. And that is how you determine your top 5 hazards. The things that Appendix Z says we have to take into consideration are your location and your geography. Most HVA templates are going to include a hurricane. Well, those of us that live in the upper Midwest are not going to encounter that. And so you can quite simply delete that from the template. The other one that you absolutely have to take into consideration is your patient population, including those with disabilities or functional access needs. So obviously, if you are a skilled nursing facility, you have a very unique patient population that has different needs than a hospital would have. You don't have ICUs, but you also have a lot of residents who aren't mobile and can't evacuate by just hopping on a bus, right? So you need to take that type of thing into consideration, as well as the types of services that you provide. Again, if you're a dialysis center or an ambulatory surgical center, you're going to have different risks and different hazards than an outpatient facility or outpatient service like a home health care agency. Again, we're going to spend another session talking about risk assessment and hazard vulnerability analysis. So this is just giving you a taste of what is new with risk assessment in Appendix Z. And that is a direct correlation to what happened with COVID, that now in your threat assessments, you must have a line that talks about emerging infectious disease. So a lot of our templates have pandemics or endemics. You can just replace that term with emerging infectious disease. And it's including any unforeseen widespread communicable disease. So they're not, don't just do influenza, don't just do Ebola. They're talking about any potentially emerging infectious disease. Again, you must consider the patient population and vulnerabilities. And then you must have include all the risks that could disrupt the facility's operations. So again, you do think a little bit in the risk assessment about specific threats, but the result of that is going to be policies and procedures that address the functions that those threats and hazards are going to lift up for you. So again, we'll talk a lot more about that as we get into this session in the future and of these 9 sessions, but I just want to emphasize the importance of having that emerging infectious disease in your hazard vulnerability analysis. Brian.
Yeah, as Amy goes ahead to the next slide here, I'm going to purposely spend not a lot of time on communications because I know that the next section, Amy's section, is really the meat and potatoes of this training. So go ahead to the next one. So this is referring to updates to the comms plan, the comms section of your emergency operations plan. And here's some of the key highlights. You should be prepared to report. That means reach out, communicate to your local partners and officials as requested or required. These are the types of things, this is the type of information that you should have available. And this is going to be based on the event. Do you have temporary loss or partial loss of complete functioning? What is still up and operating? What can you still do? Do you have a need to shelter in place or evacuate? That is a major, major decision. And if it were myself, I would make that decision from a unified command approach. And what I mean by that is I wouldn't make it exclusively. I would make it in conjunction with either sister facilities or a mothership if you happen to belong to a system type of a setup, or even with other local emergency response officials. Getting the right minds to the table is always a good idea. Looking at things from a different perspective is always a good idea. And to be quite honest, taking a unified command approach does provide a layer of liability protection. Collectively, people making a decision is safer than one individual making that decision. Yes, there will be one person on paper that is authorized to make that decision, But in an emergency response, ICS affords you the opportunity to make unified command decisions. If the need to evacuate is determined, what type of assistance will you need with transportation? How short are you on staff? What type of staff may you need? So the skill sets, and then any shortage of things that would enhance or ensure that responder safety and health is taken care of. You may also, again, don't just think about being the facility that's impacted. You may also be asked to communicate your ability to take in people that have been impacted by the incident. So you may be a receiving facility as well as a facility that has been impacted and needs to evacuate. Whatever reporting system that you're used to using is likely the reporting system that you're going to use during the response. And then what we always tell people is think of the 3 S's. Staff, stuff, and space is really what it boils down to when it comes to resources. Your plan needs to include how you're going to communicate decisions. And that means both internally and externally. And one of the recommendations that we would make in terms of structure and sequence of how you're going to communicate information out, start with your internal staff. Because if you don't have the resources and manpower internally, you're really not going to be able to get caught up enough to the incident to be able to allocate resources to go out and say, hey partners, we're going to need some help with this as well. So think about your internal staff that are number 1 on site, those that are off shift, and those that may be working remotely. That's where your initial calls should likely be targeted towards. In terms of external partners, then think local responders and officials, regional partners, whatever you happen to call your healthcare coalitions, and then any local government entities that could provide governmental support. The maintaining contact information is really, really hard to do. If you had a notification or a distribution list and you created it 2 weeks ago, it's out of date. Somebody has left their position. People have been added into other agencies. It's a tough one. We actually recommend quarterly updates of communication lists and contact lists. And your list needs to include other facilities. And that list must be available, and again, this is quoting right out of the new guidance, at a minimum to the emergency preparedness coordinator or person responsible during an emergency event. That could be the designee, that could be the person that was identified as incident command. But again, at minimum, that individual needs to know where that information is. I would go much deeper than that if I were an agency. We say 3 deep. I don't see why any person in your agency should not know where that notification list is. It could become critical information to everybody. You should have your primary modes of communication. You all know what your primary modes of communication are, but you do need to be thinking about those alternative modes if the primary comms go down. And that's going to be different for everybody. It's probably going to be different state by state, even jurisdiction by jurisdiction. We call that redundancy, and we always want to shoot for 3 deep in terms of modes of alternate communication. And then that last piece, showing evidence that you've maintained and updated, again, at least every 2 years or annually for long-term care facilities. A very simple way to doing that is if you happen to have just paper plans or electronic versions of your emergency response plans, just show a running tally of your version dates. And that'll indicate to your people that are coming in and assessing you that, oh, what do these version dates means? That means each time you see a different version date is a time that we updated our plans. And that should be satisfactory for showing that. So in summary, so I give Amy as much time as possible, make sure that your communications plan is as current as you can get it. Can you launch it quickly? Can you brief internal leadership? Can you communicate with all of your employees, your clients, and their families, as well as the local community? Do you know who your public information officer is? That individual is going to become very, very important. That's the person you want in front of the camera, or that's the person you want prepping the individual that's going to go in front of the camera. And then be thinking about how to prepare and issue statements. That's called risk communication. Are you going to be able to organize, monitor, and facilitate media coverage? In our world, we call that media staging area. You're going to want to think about, if this becomes a high profile situation, the media will be there likely before the first responders will be there. You're going to want to have a plan of where to stage them. And then again, consider utilizing communication systems that already exist. Okay, so think about your school districts. Think about your local governmental entities. They have mass notification systems and you don't. Reach out and ask. If we get into a pinch, could we leverage your mass notification systems? And you'd be surprised how many of your local partners would allow that.
In fact, almost every county will have some type of mass notification system. Some people call it Code Red, Send Word Now. And there's just a multitude of products out there, but that is something that you could certainly piggyback on, or at least have the conversation about how you could potentially do that. Thank you, Brian. So moving into policies and procedures. Brian, can you mute again? Okay. So again, really important message in Appendix Z is that your policies and procedures have to be tied directly to your risk assessment. So again, if your top hazard is extreme cold or extreme heat that could potentially result in sheltering in place or evacuation, then you must have a policy and procedure that talks to evacuation and sheltering in place. If your top risk is acts of threat or violence, someone coming into your facility and causing harm to people, then you need to have a policy or a procedure in place for how you're going to lock down your facility, or how you're going to manage or mitigate the potential for a bad actor to come into your facility. So always be thinking about that risk assessment when you're reviewing your policies and your procedures. Describe in those policies and procedures how you're going to care for your residents, how are you going to care for your patients, and how are you going to care for your staff. And a lot of that, again, gets tied into the communication plan. How are we going to let our families know what's happening? How are we going to manage this incident internally to help care for the people that are in our care? So there are several additions in Appendix Z to policies and procedures, and I'm going to go through about 10 of them that really stood out to me. The first one is considerations during a public health emergency. And again, obviously, this came directly from our COVID experience. So they are now asking every facility to have in their EOP a plan or a policy or a procedure that talks about PPE, that talks about how you're going to screen and test your patients, your visitors, your staff, how you're going to transfer or discharge patients. So part of this is around things like, how do you utilize telehealth? How do you evaluate if a patient needs to be transferred to the hospital? How do you isolate patients or residents within your facility if you have that capability? One of the answers may simply be, for example, screening and testing of patients, is we're going to follow the guidance from our local public health department. That can be written into your plan or policy, because again, when we went through COVID, you weren't all creating that on your own. You were receiving guidance from the federal government as well as from your state and local officials. So stating in your policy that you are going to adhere to whatever recommendations come would be one step towards having that plan in place. Physical environment, again, think about the things that you actually did during COVID. What were some of the changes and procedures that allowed you to maintain the appropriate distance, or to expand your surge capacity, or take care of isolation and quarantine? This is an opportunity to document and to build into our plans and policies, incorporate the lessons learned from COVID, so that when the next time comes, we at least have a place to start and we don't have to be reinventing the wheel, which is something that with turnover and all of the other things that happen in our facilities, we want to be able to point to some place where we know this has worked in the past, so we're going to write it into policy, or we're going to write it into procedure so that we can do it again in the future. Because everything tells us, with climate change and everything that's happening, that we probably will see something again in our work careers. So those are some of the things that are specifically stated in Appendix Z that must be addressed in your policy and procedure for considerations during a public health emergency. Mobility and transfers. Again, how do you ensure patient or resident safety when you are transporting them? And under what circumstances would a patient transfer occur? So again, this comes directly out of Appendix Z, page 27. They want you to be
Right. That Eric and Lily.
Somebody needs to mute. Thank you. So, for example, in the past, we've had situations where we've had to transfer residents. Well, if you provide a certain level of care to that resident, you must, when you transport them or transfer them, you must transfer them to a like facility. You can't transfer them to a lower level of care. So that takes some planning, and that means identifying your sister facilities. It means thinking about the fact that you can't just get a school bus to get most of your long-term care residents out of your facility, because many of them can't do stairs. So then how are you going to find enough wheelchair accessible vehicles? What other types of modes of transportation do you have? These are all things that should be thought about or thought through as you're writing this policy. And then also, again, what are those triggers that would trigger the need to transfer a patient? Those are all things that Appendix Z is asking you to look at. And these are questions that come directly from that survey procedures section of Appendix Z. A surveyor could ask you, how will you facilitate and ensure patient safety or resident safety during a transport? Maybe it means sending staff along. You'll have to come up with the ways that you're going to plan to do that. Secession and delegation of authority. One of the reasons why there's some changes to this section is because we've had nursing home administrators who became very ill or died during COVID. And there was nobody within that policy and procedure of that organization that had written authority to make decisions in the place of that administrator. That's a really big lesson learned. So one of the new requirements is that you must have a qualified person who is authorized in writing to act in the absence of that administrator. So again, 3 deep. Who are those people? Maybe it's your director of nursing who comes next. Maybe it's the director of facilities. It just depends what your individual organization or facility feels is appropriate, but it must be written down and they must have written authority. Who has the authority to activate incident command within your organization? Or who has the authority to say, we really need to pull out this emergency operations plan and think about what steps we're going to take? Hopefully that's going to be, again, your administrator. But what if your administrator is on vacation in Mexico, right? And can't be reached by cell phone? or fishing in the boundary waters, right? In the summertime, that's my favorite illustration. Those people should be written down in your plan and your policy to demonstrate secession and delegation of authority. The other question that can come from the surveyor is to ask people, what role would you play within incident command? So again, they're not going to just walk up to any person on the floor probably, but they could ask this question within your leadership circle and say, if you had activated incident command, what role would you likely play? And it may be the liaison officer, it may be the public health or public information officer, it might be the safety officer. They don't need to know exactly what's in every job action sheet, but the people within your leadership circle should have an understanding. First of all, what is incident command? And second of all, what role could they potentially be playing within that incident command structure? And as Brian said earlier, we will be dedicating again another entire session to nursing home incident command, but really at the level that we're going to be looking at it, it will make sense for everybody. The next is cooperation and collaboration. And really the best way to think about this is how well do you play in the sandbox? When I work with organizations and facilities in emergency preparedness, I find that sometimes they forget that the emergency will most likely go beyond their four walls. We become very focused on what happens within our organization, which makes sense, but we also have to think about how do we work with the people who will be coming to our organization or facility in an emergency, and how do we leverage those partnerships? Even if we're not part of the same system or the part of the same organization, we may need our nursing home across the street or across town, or the hospital across town, or the dialysis facility across town. We may need them when we're facing an emergency. So how willing are you to become involved with those LEPCs for your community, or those opportunities to be involved in your healthcare coalition, to get to know your neighbors, to build networks and partnerships? That is really what this is all about. One of the questions that the surveyor could ask is, tell me about your relationship with your local or state officials during a public health emergency. If you don't have the phone number for your county emergency management or county public health officer, that is a potential area red flag, right? You need to have those contacts, and it's even best if you have a relationship with those individuals. And then again, how aware are you of state plans? If we do find ourselves in another public health emergency, how do you become aware of the recommendations coming down from the state? Are you on the listserv for that particular agency? Do you participate in the assisted living or the nursing home long-term care forums that your state agency offers? Those are all things that you can document and demonstrate that you are a part of. And all of those pieces come together to demonstrate how well you do play in the sandbox. Emergency provisions. This is a tricky one as well. So this is talking about, what do you need to have on hand in terms of emergency provisions? So we all know that, you know, the Be Ready campaigns, it talks about, you know, build a kit, have a kit in your home, make sure you have your flashlights, and you've got your medications, and you've got your blankets, and you've got enough water, and you've got enough food to last you, in general, they say about 72 hours, because depending on the incident, emergency support may not get to you for 72 hours. Again, within the facility, hospitals are expected to have 96-hour sustainability plans. Nursing homes, there's no particular amount of stuff that you're supposed to have on hand, nor is there a time limit like this. But it's important, this is lifted directly from Appendix Z. Inpatient facilities need to demonstrate their plan to have enough water, food, medicines, etc., for staff, patients, and residents during an emergency, regardless of evacuation. So again, if you think about your risk, how long is a typical blizzard? Do you have enough stuff to sustain the people within your four walls for 3 to 4 days, 2 to 3 days, whatever you determine makes sense? Alternate sources of energy. Again, it's up to each facility based on your risk to determine what is the most appropriate type. The thing that has been added in Appendix Z is that you need to be able to continue treatments. So if you have residents that get nebulizer treatments, if you have patients that need dialysis, you are supposed to be able to demonstrate that you have a generator or a power pack or some type of alternate source of energy so that you can sustain that same continuity and same level of treatment. And that gets tricky. I'm rushing a little bit here because I want to get through everything. Evacuations. Okay. A lot of information around evacuations. We're going to talk again about evacuation in another one of our presentations. But the question is, how do you track your patients, your residents, and your staff? So you've managed to get them out of the building, but who knows where they are? Because when the family starts calling and saying, well, where did grandma go? You need to be able to tell them exactly where that individual patient or resident went. Same thing with the staff. That is now a requirement. What is your triage plan? Who makes a decision about who leaves the building first? In a hospital setting, oftentimes we say the most critical patient goes first. But maybe it makes more sense in some facilities to take a bus full of the people that are most mobile, get the most people out of the building first, and then work on the more critical patients. That is a decision that your individual organization is going to need to think about. How do you communicate to the receiving facility? You can't just take a bus or take an ambulance and drop someone off at the door. They need to have medical records, family contacts. They need to understand what this patient or resident, what their needs are so that they know how to appropriately treat them. How do you communicate? And what do you do? This is a new question in Appendix Z from the surveyor section. What would you do if a patient or a resident refuses to evacuate? There's not necessarily a right or wrong answer to this, but you need to have thought through this. And if you have it written into your policy, all the better. Emergency staffing. Again, lessons learned from COVID. What lessons did you learn about how you're going to preserve your healthcare system staffing level? And I know that this is an ongoing issue and all of our healthcare facilities are struggling with this right now. But think about, what are your agencies, nurses? What are their contact information? How would you utilize your medical reserve corps if you have one within your jurisdiction? How would you utilize volunteers? Those are all things that could be included in your plan and policy for emergency staffing. Additional things to think about with staffing is, how would you incorporate the use of telehealth, advice call lines, patient portals? Again, what are your protocols for quick triage and assessment? How do you determine if somebody can stay at home or needs to go to the emergency department? Again, what types of healthcare personnel? Would you accept a volunteer? Would you accept a retired nurse who maybe doesn't have their license up to speed anymore? I mean, these are all kinds of questions that we need to be thinking about and are strongly encouraged to have in our plans. Transfer agreements. Again, it's important that we think about our patient population and continuity of care. If you get to a situation where you have MOUs, for example, memorandums of understanding with sister facilities, it's strongly recommended that not only do you review those transfer agreements every 2 years or every year for long-term care, but also renew or revise any of your transportation agreements. So transfer is where you're moving, where are you moving the resident to? Transportation is how are you getting them there? And so again, you have to demonstrate that you're looking at those and not making assumptions that what worked 5 years ago is going to work today. And finally, 1135 waivers. This is a federal waiver that comes down when there's a national declared emergency. But your leadership team has to have a basic understanding of how does the 1135 waiver change what's happening within your facility during a public health emergency or in an alternate care site. What are the flexibilities that you do and do not have? The key kicker here is that when that 1135 waiver ends, you need to be able to go back to regular practice as soon as that emergency ends. So we all know that the COVID public health emergency is due to end in May. We have to be ready to flip back to all the expectations, everything that we had to do without the 1135 waiver. We have to pick up and be ready to go by the next day. So having that general understanding of what an 1135 waiver is, when it gets issued, how it gets issued, and what kind of flexibilities may or may not be afforded with an 1135 waiver. And I know we're really tight on time. My bad. Go for it, Brian.
I think one of the things that we could do is if the moderators have any questions that are queued up, we could certainly address those at this time. I know that the slide deck has been sent out multiple times, but the last piece I can touch on really quickly here. These are just different variations of exercises or drills that you could do. This is talking about the training component. And again, you can see the pages under the Appendix C guidance that you would refer to, how you go about them, how you count them, how you document them. But again, key takeaway point is tie that training plan back to your risk assessment. And we've even seen people lay out training plans. We're going to do this training, and in parentheses, ties to this particular risk. And you're being very black and white about how you're showing that there's a methodology to the trainings that you identified. And the last thing I would say before I turn it back over to moderators is don't make preparedness training an add-on, one more thing. Embed it into things that already exist. So for example, if you have monthly or every other week staff meetings, build a 5-minute standing agenda item into that existing meeting about one preparedness topic. And that way your staff aren't going to see this as, oh my gosh, we're already overworked and overwhelmed. Now we have to go to another meeting for emergency preparedness. It's already integrated into things that they're already used to. Last thing on an after action report, again, you're supposed to identify, this is the quality improvement piece of events and real events and exercises. You identify what you did good and you identify what you fell flat on your face on. And there will be times when we fall flat on our face. That is an opportunity for quality improvement. And that's how you should look at emergency preparedness. As Amy said, not punitive, opportunity to improve. And I will pause there.
And again, I apologize. We knew this would be a tight one. There is some great links here that I would encourage you to look at. And again, Brian and I are very happy to field questions. If we don't get them answered here, you can always email us and we'd be happy to try to help you.
Thank you, Brian and Amy. Allie, do we have any questions in the chat?
I have not seen any at this time.
Okay. If anyone wants to ask a question, you can unmute yourself, or if you're on the phone, just click on *6. Okay, could you go to the very last slide, please, Amy? So just to let you know that Superior Health, we are helping nursing home and community organizations out with their emergency preparedness plans. But in order to do that, we have just a couple of questions you need to answer related to that. So those links are on this slide. Just a reminder that we would appreciate if you would fill out the evaluation that I believe, Mike, have you put that in the chat?
It's in the chat. Also, we have a question about handouts, where they can get handouts from.
Yeah, well, you put those in several times, haven't you, Mike? Do you want to put it in one more time?
Absolutely.
Okay, sounds good. So the next webinar in this series will be on March 2nd, and it is on risk management and emergency preparedness planning. And we are looking forward to seeing you all again. And thanks again very much, Amy and Brian, for the great information that you shared with us today. Everyone have a great afternoon.
You're welcome. Thank you.